Good afternoon. I'm Tanisha Sullivan, Head of External Engagement and Health Equity Strategies at Sanofi. I am very excited to be joined today for what I believe will be a thought-provoking conversation about health equity and more specifically, what we need to do to help close life expectancy gaps here in the greater Boston area, across the Commonwealth, and nationally. I am thrilled to be joined today by Dr. Bisola Ojikutu, the Commissioner for the Boston Public Health Commission, Dr. Robbie Goldstein, the Commissioner for the Massachusetts Department of Public Health, and joining us virtually, Dr. Joseph Bentecourt, the President and CEO for the Commonwealth Fund. Good afternoon.
Afternoon.
We have a lot to talk about, and so I'm going to jump right in. When we talk about life expectancy gaps, what we have heard time and time again is that they persist. Here in Boston, what we hear is that whether we could have a 3-mile distance between Roxbury and the Back Bay and see life expectancy gaps of upwards of 15 years or so, meaning where you live can be a determining factor in how long you live. Nationally, Dr. Bentecourt will talk about this as well. Nationally, those types of gaps persist, and even more so what we see is that for Black Americans, American Indians, Indigenous communities, that life expectancy gaps are still holding and significantly and raise significant concerns. So I want to talk about some of the issues. You all are the experts in helping us to identify and understand those issues, but I also want to talk about what are the breakthroughs? What are we excited about across the country and here in the Commonwealth that's working? Dr. Ojikutu, I want to start with you. Last year, the Boston Public Health Commission released your most recent mortality and life expectancy gap report, which really helped to shed a light on some of the very important data points relative to mortality and life expectancy here in Boston. Could you share a little bit about that report and how you hope it will be used?
Sure. Thank you so much. Well, let me talk about the issue of persistence that you mentioned, because I think that's part of the story here. So probably about, I would say 12 years ago, a report was released which demonstrated that there was a life expectancy gap of 33 years between a census tract, so a small area in Roxbury, and also a small area in Back Bay. Okay, so that's about a 2.3, 2.5 mile distance. So when I started in my role in 2021, I said, well, the first thing we got to do, that's more than a decade old. Let's update that data. Something has happened. There's been a lot of work in Massachusetts, lots of work in Boston. And what we found was that there's now a 23-year life expectancy gap, similar census tracts in Roxbury and Back Bay. But I think what's important to note is that a lot of talk has been about Roxbury and how, low the life expectancy is. But if we look around our city of Boston, there are actually pockets of relative disadvantage in lower life expectancy in multiple neighborhoods. So it's in Dorchester, in Mattapan, in East Boston, areas of Alston. So there are these areas, and you have to think to yourself, so what is different about these areas than the rest of the neighborhood? I think the other piece that's really important is that when you look at life expectancy overall in Boston, we have one of the highest life expectancies if you look at urban centers across the US. So in 2023, our life expectancy around 82 years of age, okay? But so if you stop there and you said to yourself, we're doing just fine, you'd miss the story. Yeah. So then you have to look down a little bit deeper to the neighborhoods, and that's where you start to see differences, but not as wide as the 23 years. It's really when you drill down, when you zoom in to really think about what's happening at the community level. That's when you get an understanding of what's truly happening in terms of gaps and inequities.
Thank you. Thank you. And we're going to come back to that because I want to dig a little deeper on a few of the points you made. But before we get there, Dr. Goldstein, I'd love for you to share with us what we are seeing at the state level earlier this year, really delivering on a commitment of the Healey-Driscoll administration to lead with equity. Your department released a health equity framework and new initiatives that are designed to help tackle some of the disparities that we see in health outcomes. Could you talk a little bit about that?
Yeah, I'm happy to. So, I think first we have to take a step back and look at our state and recognize what we'll probably hear from Joe in a minute or two, that we are ranked really high for health outcomes in this state. This year, the Commonwealth Fund told us that we were ranked #1 for maternal health. Last year, we were ranked #1 for healthcare access. And that is really great. But as we just heard, if you really drill down and dive into the details, there are these enormous disparities that exist across the state, not just in Boston. And so recognizing that, the Healy-Driscoll administration put out a plan called Advancing Health Equity in Massachusetts, a statewide plan that is really led by the Executive Office of Health and Human Services, which I'll remind people is 50% of state government. So 50% of the budget, 50% of the workers, 50% of the programs, 50% of the impact of state government. And it is a way for all of us to come together and to address the two biggest drivers that we see in this moment in premature mortality or decreased life expectancy. One of which is cardiometabolic disease, so heart disease, stroke, hypertension, diabetes, really focusing our efforts there. And another is to think about maternal morbidity and maternal mortality, recognizing that in the state, while we are #1 for maternal health, Black birthing people in this state have unacceptably high levels of severe maternal morbidity, unacceptable levels of maternal mortality, and we have to collectively address that. So we've come together on these two major ideas, cardiometabolic disease and maternal morbidity and maternal health, and we've also said that we have to do this work differently. We definitely need a statewide approach, but we also have to recognize there are areas that have disproportionate burden of these inequities. And so we've gone through the data and we've selected 10 communities across Massachusetts, 10 communities where we know there are inequities that exist, and we're going to use all of our energy collectively, all of our funding collectively to try to advance the programs that we think are going to have an impact and really make a difference in life expectancy.
Very good, very good. And so with that, you mentioned Dr. Bentecourt, so I do want to bring Dr. Bentecourt into the conversation. And actually, Dr. Bentecourt, could you just share a little bit with us about kind of the focus of the Commonwealth Fund so that folks can better understand really the important work that you're doing nationally? And then share with us a bit about your most recent health equity report and what it tells us about life expectancy across the country.
Well, first, thank you so much for the kind invitation. And I just want to say Massachusetts is blessed to have such fantastic leaders as the two colleagues and friends that I share the stage with. It's no coincidence that Massachusetts ranks as high as it does with that type of leadership and vision. So a couple of things I'd say. The Commonwealth Fund is a foundation established in 1918. Our mission is affordable, high quality healthcare for everyone. And we focus on advancing policy, practice, and leadership development in that space. One of the things we do is focus on report cards of different types. Just this past week, we released a major report card called Mirror Mirror, just by context, that compares the U.S. to 9 other similar countries around the globe, economically developed countries, OECD nations. And just to put this in context in the bigger picture, the U.S. spends the most on healthcare compared to any other nation, and we have the least to show for it. Lowest life expectancy, highest infant mortality, most chronic disease, largest disparities. And so that's the national context. If we look at the state context, our state equity report, and as was mentioned, our state scorecard demonstrates that state policy matters, federal policy matters, but Massachusetts has been able to do some things that are, I think, quite unique and become a lesson for the rest of the nation, but the work is not done. Our state equity report card shows that every state, all 50 states and the District of Columbia, still have disparities in health outcomes and in healthcare, including Massachusetts, who, although we rank #1, still has significant disparities. What are the lessons? If we compare ourselves, Massachusetts, to other states, there's 3 things that we do that differentiate ourselves from other states. #1, universal healthcare coverage. Insurance is absolutely essential. And so that's a key success factor. We expanded Medicaid, Mass Health. Second is we have focused on the social drivers of health, the types of things that are impacting those exact communities that Robbie's talking about us focusing on, and that Bisola is talking about us focusing on within the city of Boston. And third, we are unique in our investments in health equity. We have something called the Health Equity Compact, leaders who've centered health equity in our work. So there's a reason we're #1, but we still have a long way to go. And I would argue that, yes, we need to focus on these key areas, cardiovascular disease and absolute maternal health, where we perform poorly globally and as a state areas for improvement. It's interesting to note as well for the Latino population that whereas heart disease is the nation's largest killer and the largest killer of individuals in Massachusetts, cancer has now surpassed that for the Latino population. #1 killer for the Latino population, highly preventable. So this idea that we can customize to communities as well I think becomes a key strategy for the future.
Very good. And just a wonderful way to kind of lay the foundation for our time together. I want to go back to this piece around communities and some of what we're seeing, whether it's in the city of Boston, here in across the Commonwealth or nationally, that there are pockets of communities within the same city that experience differentiation in life expectancy and mortality rates. What are some of the drivers? I want to, so let me just give you the answer. Like, I want to talk about social determinants of health, right? What are some of the other drivers that we're seeing that perhaps we could find solutions for? I'll start with Dr. Bisola.
Sure, I think that's really the key issue. It's like, how are we going to develop interventions if we don't really know the drivers? So there have been many studies at this point where researchers have actually looked at what are the true drivers of life expectancy, of premature mortality, of quality of life. Because again, we can extend life as long as we want, but if it's not higher quality, then what is the point, to be honest with you? So what are the true drivers? Well, it's multifactorial, but I want to emphasize that these social determinants of health, the conditions in which we live, work, play, and eventually die, these are the factors that most predict, if you just look percentage-wise, these outcomes like life expectancy, premature mortality. That's not to say clinical care is extremely important. Individual behaviors, important. But if you really want to look at just categories of things, groups of things. So if you think about social determinants of health, we're talking about housing, we're talking about employment, we're talking about income, and I would like to say we're talking more about wealth than we are income. Harder to measure wealth, but the studies that have actually looked at wealth and looked at associations between wealth and health have found a significant association between the two. And by wealth, I mean the difference between our assets and our debts. So then the question is, what are we doing differently in Massachusetts that overall predicts higher life expectancy? Personally, I think that we have intentionally, as Joe mentioned so clearly, we've intentionally focused on social determinants of health. I think we have had leadership that has put effort, energy, and invested there. But the question is, this difference between one census tract, one small area, and another, that's centuries in the making. That's not about what's happened in the last 10 years. That has been an issue of structural racism and systemic inequities, deeply embedded issues, systematic disinvestment from communities. That takes time, effort, and concerted energy in order to overcome. I think we're on our way. The Health Equity Compact, as Joe mentioned, a great group of leaders, Black and brown individuals, leaders across the state. We have wonderful leadership at the Department of Health, wonderful leadership in EHS, but it's going to take a lot of effort, intentional effort, to overcome these challenges. I would say that one of the things that we in Boston are particularly focused in is this issue of economic mobility and wealth creation, because we think that that's one of the areas where there maybe hasn't been enough effort. Whereas, like I said, a lot in housing, a lot of investments that have made recently in housing, a lot in education, built environment, still a lot of differences between built environment if you look across the city of Boston and across Massachusetts. But what can we do in terms of economic mobility? So our Live Long and Well agenda is actually focused on economic mobility right now. We have a $10 million investment from Atrius Health Equity Foundation. We will be releasing an RFP very soon, looking for community coalitions that'll think about how do we get wealth built in these communities where we see lower life expectancy.
Dr. Goldstein, I see you shaking your head. So let's dig a little bit there around the socioeconomic piece, if you will. What can you add to that?
Yeah, well, I want to just sort of highlight one piece that Bisola brought up here about the past 10 years, right? So last year in June or July of 2023, we put out a report on maternal mortality and maternal morbidity in the state. And what we showed was that over a 10-year period, maternal morbidity increased for everyone across the state, all birthing people in the state. And that's a trend we're seeing nationally. But what was really shocking was that the rate of increase was steeper for Black birthing people in the state. And so 10 years ago, the difference between Black and white birthing people was about twofold. And 10 years later, it was 2.5-fold, right? This really big jump. And I think we could talk about all of the social determinants of health that resulted in that. Some of the pieces about lack of access to care and the care that's being delivered. But we can't have that conversation if we don't name exactly what the problem was here. And the problem was racism. Right? The problem was that Black birthing people were showing up in a birthing center, in a hospital, and not listened to. They were not getting the care that they needed. They were not receiving the type of care that we would expect here in Massachusetts. And because of that, more Black birthing people had severe maternal morbidity events, and more of them died. And that, I think, explicit acknowledgement of racism as the underlying cause of these disparities that we're all talking about is what I think we have to do as a state right now. We have to be clear. We have to be explicit, not exclusive. There's a lot that goes into health equity. We have to think about race and ethnicity and geography, and we certainly have to think about economic diversity across the state. But if we don't explicitly start with race, we are going to continue to see these increases and these gaps that are just unacceptable.
That's a powerful statement. And I'm curious, Dr. Bentecourt, does that hold true across the country, race really being a leading determining factor in health outcomes?
On this area, my entire career, more than 25 years. And, the notion that there's still any debate about racial and ethnic disparities in health outcomes and health care, I think has long been dispelled. The evidence is clear. We know that structural racism and other factors play a role. I think just like anything we do as a society and in healthcare, good data gives us then the springboard for taking action. And so absolutely, I mean, it is there are components of this that are intersectional, but race does carry the day, sadly, when we see these differences in health outcomes. And maternal mortality is a great example. When we looked at our statewide women's health report, clearly we're double the next industrialized nation, and Black women are double our national average as it relates to maternal mortality. So this is something that requires a lot of attention. And this isn't just about, to be clear, poor Black individuals. It crosses socioeconomic status. So whereas people like to say, well, isn't this more about class? We like to say it's about both, but race is solidly in this conversation, and the evidence is clear.
So here we are in the Commonwealth of Massachusetts, the city of Boston, arguably the hub for not only innovation, but healthcare, academic research, scientific research. We are known for breakthroughs time and time again. That's what we do. We take on the tough problems and we solve them, not just for ourselves, but for the world. How is it that we are still really struggling to close these gaps? And what are you seeing that gives you hope? And I'm looking at you, Dr. Goldstein.
This was said earlier, these are centuries old problems. And to think that we would solve them in 5 years, 10 years, that's just not realistic. It is going to take us time. They're hard problems, and we have to accept that they're hard problems. We have to do hard work to address them. But I actually think there's a lot of hope out there. I think there's a lot of innovation that is happening in Massachusetts. Part of advancing health equity in Massachusetts is about going out into the communities and innovating with community engagement, right? Making sure that we're flipping the script. We just put out a really great grant opportunity from the Department of Public Health where we went to the community and we said, what do you want money for? Not here's the money that we're going to give you because we think this is the best thing, but you, the community, what do you think is the best way to spend this money? That's actually innovative for government, which is saying something about government. But I think we've got to go out, we've got to engage with communities, we've got to let them drive our policies and our practices. I also have to say, we're using mobile vans and mobile integrated health and in a way that I don't think we could have thought of 10 years ago. Yeah, people had vans 10 years ago and people went out in different places, but we go out now and we vaccinate people. We get them signed up for healthcare. We check their blood pressure. We do virtual visits in the van because we need the specialists to come in. We're doing really amazing things that can get out into the communities where people are and making sure that they get the same care, whether they live directly next to an academic medical center or they live in a rural area in Western Massachusetts.
Dr. Ojikutu, we also are we not only take on the tough problems, we like to debate the tough problems and the potential solutions. And as has been noted, we spent a lot of time thinking about this issue because it matters to us here. We actually care about finding a solution. How do we get to the actionable solutions faster? How do we get to, okay, we're done having the conversations, now it's time to act? How do we do that?
So I think that's a great question. And most of what I talk about is how do we get to action? Because I do think we spend a lot of time talking, we spend a lot of time debating. I think one of the things that gives me hope at this time is the fact that we are moving more towards action. I don't believe that a decade ago, when this report that I mentioned earlier said 33 years, there were no individuals, no companies, no foundations who were necessarily running to the table to say, oh, here's $10 million. Let's make this a catalytic investment. Let's open the door and let's get other, private sector folks to the table to say, this is what's really important. Let's not just make this a Black problem or a Latino problem. Let's make this our problem as a world, as a society. So for me, that does give me hope. I think the challenge, though, is that, I have to be realistic. And I know that I drive through the city of Boston, you look to one side and you look to the other side, and you know that there are a lot of people who are not paying attention to this. And so for me, even though we're here, and I think we spend all of our lives, our careers thinking about these issues, the question for me is, how do we get beyond the talking, and how do we think more about what the community wants? Because as Robbie said, community leadership is actually a novel thing, unfortunately, which is crazy, right? I mean, if you're talking about somebody with lived experience who lives in a community, why is that a novel thing? So there's a delay in the obvious, acting on the obvious. And that's what still worries me, even as I speak about hope and breakthroughs, and I'm happy that we have this money. Let's move this into community. Let's fund communities directly to deal with some of these issues. Because quite frankly, I hear, my colleague, Joe, and we're talking about racism. A lot of this is happening within institutions. Health inequity doesn't, from my perspective, begin within the walls of healthcare institutions. Think about this. In Boston, we've got 22 federally qualified health centers. We have these amazing academic institutions at which we've all practiced. And yet we still have the gaps that we're talking about. It doesn't begin there and it won't end there. We need to be in the community and think about these issues that I said about community disinvestment. It's a team effort, but it's also thinking about this on multiple levels.
Yes. So I wonder, thank you for that. And Dr. Bentecourt, I want to come back to you because a lot of the work that you do with the Commonwealth Fund is certainly the research piece, but really providing information to policymakers, those who have those official titles, as well as those who are advocates externally, but policymakers to really help inform some of their decision making. Can you share a little bit about what you're seeing nationally as it relates to the advancement of policy, public policy, that can help address some of these issues?
And I'll reflect a bit as well, having done work in this space and seeing the evolution of health equity over the years. And I'd say, for all too often and for all too long, we had organizations who were I think early adopters, who had progressive leaders who made health equity a nice to do. And I think from a policy standpoint, we move it from a nice to do to a need to do. And we really embed it, build it in as opposed to bolt it on. That, to me, after my journey in this work, is really where the difference is going to be made. What does that look like? That really is about leadership. That really is about payment. And that really is about accountability. We've been able to move many, many areas in society and in health when we've aligned those three things. And I think they haven't been aligned well around health equity. I think we have great leadership now. I think we need to build more accountability and certainly payment and how we pay providers and what we invest in. Social drivers, healthcare coverage, and healthcare is really, really critical. And I'll just say that as it relates to health equity, just like everything, when something's wrong with the system, it impacts communities of color 10 times worse. We're in the midst of a horrible primary care crisis right now. And this primary care crisis is incredibly challenging, and it is disproportionately impacting communities of color. So we need to be thoughtful about that. And we need to say our investments in primary care not only are critical to good health and well-being, but also thinking about how we customize those and make sure that communities of color aren't left behind is even more important, I would argue, as we think about health equity.
I want to make sure that everyone understands what you're referring to when you talk about the primary care crisis that we're experiencing nationally and even here in the greater Boston area. Can you just expound on it for
absolutely. So one thing that I'll draw on from our international survey, I mentioned how other countries do much better than us in health outcomes and life expectancy and the like. Another big thing that I didn't mention is that on average, those countries spend 14% of their healthcare spend on primary care, while the US spends 5%. If we think about the primary care workforce in the United States, the wage gap between primary care doctors and specialists is the largest of any developed nation. That impacts people's decisions about whether to go into primary care. The average age of a primary care doctor in the United States is 60. 3 out of 4 primary care doctors in the United States are over 65. And what we've seen from 2005 to 2015, a 10% decrease in primary care providers nationally. And from 2021 to 2022, 16,000 physicians left primary care. So we are left with what we see in Boston, a lot of doctors, but people needing to wait 3 to 4 months to see a primary care doctor. So insurance coverage does not meaningful, affordable access to care make. And I think focusing on that from a policy standpoint, in addition to the other things I mentioned, is going to be really critical.
So what that makes me think of is, working to ensure that we have broadband access, broadband coverage, that actually it works for everyone. Even here in the Commonwealth of Massachusetts, any of us who have gone out to Western Mass know that there's just spot. It's amazing.
Route 2.
Route 2, right? So even here in Massachusetts, making sure that from a policy standpoint, we're focusing on broadband access so that perhaps we can have other means for folks to have access to primary health care. Why does that matter in terms of again, when we talk about life expectancy and premature mortality, why does early intervention matter?
I think that was to me.
Yep.
And I'll say it's partly what we're talking about. It's meeting people where they are.
Good.
Right? Mm-hmm. It is recognizing that not everyone feels comfortable going into a primary care office or going into a hospital. Not everyone has been treated well going into a primary care office. I'll bring in a different part of health equity here. I spent a lot of time as a primary care doc in a transgender health program, right? Caring for people who were told explicitly, we don't want you in our practice. And they still hear that in many parts of the country. We need to make sure that we are meeting people where they are. If people can have a visit from the comfort of their own bedroom, where they can be who they are, they can feel comfortable, they can feel affirmed, they will then engage with healthcare. And that engagement is what we're looking for, because that's how we get to the next step, right? That's how we address the underlying health issues that lead to the decreased life expectancy.
Absolutely. And thank you for lifting up once again, and certainly Dr. Ojikutu did as well. This is, while race is clearly an issue that we've got to wrestle with when we're talking about health equity and life expectancy gaps, what we're really talking about is underserved communities writ large. So whether we're talking about LGBTQ plus communities, or we're talking about communities of color, or even those who are in rural vis-a-vis urban communities, there are even gender dynamics here. We're really talking about ensuring that, regardless of who you are, your life expectancy cannot be, hopefully at some point, not determined by your demographic label. In our closing minutes, I'm going to give each of you an opportunity to share with us briefly what your breakthrough hope is when it comes to tackling these health disparities, and specifically our life expectancy gaps. Dr. Ojikutu, I'm starting with you.
So my breakthrough hope really relates to what we started with. This idea that there are these persistent issues over time, and we didn't even get to infant mortality. Infant mortality here in Boston, Black babies, 3 times higher infant mortality. This has been going on for 30 some odd years. And we keep putting money into it. We're putting money in sort of the wrong things oftentimes. We're oftentimes putting money into things that we think we should be putting money into. And we're not always talking to the community. If I go back in the history and think about some of these disparities, oftentimes it's not community who's leading and saying, well, this is what's wrong with my life. This is why I didn't show up at the federally qualified health center that's right around the block. This is how I was treated. This is the mistrust that has been developed. This is the problem. This is the chaos in my life that stops me from accessing healthcare in a city where we are actually resource rich in regards to healthcare. So what I would like to see, I would like to see community really leading the work, and leading it robustly and leading it authentically, meaning not the games that are sometimes played. I really want to see community leading it and bringing ideas to the table, and let's make those ideas actionable. Let's put money behind them.
Excellent. Thank you. Dr. Bentecourt, I'm giving you about 5 seconds.
Yep. All I'd say is we want to see measurable progress. We're a national leader, and we should be continue to be a national leader in health equity and be able to demonstrate that we've achieved that. So it's a journey, but continuing to build on this and making it sustainable is critical.
Excellent. Dr. Goldstein.
Oh.
I think we're out of time. So, but I want to thank you all for being with us today and thank the Globe for our time together.